Assalamu alaikum, dear students. Welcome to today's class. So, as usual, before starting my class, I would like to just remind you regarding the importance of my videos. Why these videos are important. One reason is they are very precise and exam oriented, and second is they are very interesting and simple presentations. So, and only one video or one question or one topic is covered in each video. So please like, subscribe, and share my channel. So with this introduction, we'll start today's topic. So we have one important topic today covered here. It's proximal humerus fracture. So proximal humerus fracture is very important fracture. Today we'll start our class with this case. We have a 60-year-old female patient. She had fall at home. So she is a 60-year-old patient. So 60-year-old female patient means an osteoporotic patient. She had fall at home. So she presented to us with pain and the swelling around the shoulder joint, and there are bruises along the shoulder and axillary region. This indicates that patient is having injury to the proximal aspect of the humerus. So this is the mechanism of injury. Patient fell onto the shoulder and sustained injury to the shoulder joint. Okay. Then there are bruises around the shoulder. So here you can find the bruises around the axillary region and the shoulder joint. And on clinical examination, there is deficit of the sensory distribution along the upper arm. So over this region, patient is having sensory deficit on the upper outer aspect of the arm. So that indicate that patient is having injury to the shoulder joint or a proximal aspect of the humerus, and there is injury over the axillary nerve. Axillary nerve got injured. So this is how the proximal humerus fracture present to us. So any fracture around the proximal end of the humerus, they are considered as proximal humerus fracture. What is the etiology of proximal humerus fracture? They may result from very high velocity injury, road traffic accident in younger individual, whereas in osteoporotic individual, it is just a trivial fall. So in osteoporosis, the patient will have just a fall over the ground from the standing height and sustain injury to the shoulder, resulting in proximal humerus fracture. And very rare but not uncommon is the seizures. So patient has episode of seizures, and after that patient will have the injury to the proximal humerus. So one more injury of the shoulder joint which is associated with seizures is posterior shoulder dislocation. We have read regarding the posterior shoulder dislocation in the previous class. So to brief about the anatomy of the proximal humerus and the shoulder joint, this is your shoulder joint, the head of the humerus, glenoid. So we have anteriorly the subscapularis muscles are coming all the way from the subscapularis fossa. Then we have the coracoid here. Then over the coracoid, we have the rotator cuff, that is your supraspinatus. And the lower anterior aspect of the humerus, upper anterior aspect of the humerus, we have attachment of pectoralis major muscle. So these are the three muscles which are important when we examine from anteriorly. And superiorly, we have one muscles arising at the superior aspect of the acromion and the clavicle, that is your deltoid muscles. So basically, we have four muscles here. One is deltoid muscles, supraspinatus, subscapularis, and teres major. Why these muscles are important is when these muscles attach to each part of the proximal humerus, and the forces along this result in the displacement of the fracture to their action of the pull. So this is the attachment of this is a part of the head of the humerus. So if you see, this is head of the humerus. This is your anatomical neck. Anatomical neck is attachment of the head of the humerus to the proximal aspect of the humerus. This is anatomical neck. Anatomical neck. Then this is your surgical neck. It's just lower to the greater and lesser tuberosity. Then you have greater tuberosity. We have lesser tuberosity. The muscle inserted on lesser tuberosity is subscapularis. This is the muscle inserted here, subscapularis. Whereas on the greater tuberosity, this is your greater tuberosity. We have supraspinatus, infraspinatus, and teres minor. greater tuberosity, supraspinatus, infraspinatus, and teres minor. So out of the anatomy, what are the things you need to remember? There is a surgical neck. There is called as the anatomical neck. The attachment on the greater tuberosity is supraspinatus, infraspinatus, and teres minor. On the lesser tuberosity, we have a subscapularis insertion. So below the tuberosities, we have the part of the head of the part of the proximal humerus, which is called as surgical neck of the humerus. So with this brief anatomy, we'll move on to the topic for today. So if you see here, this name of this classification is very important because it was many times asked in your PG bit. NIRS classification is for proximal humerus fracture. It's for proximal humerus fracture. Okay, NIRS classification is used to classify the fracture around the proximal humerus. So what are the, just now we have this is your surgical neck, anatomical neck, sorry. If you see here, this is head of the humerus. This is your anatomical neck. Okay, anatomical neck. Then comes your greater tuberosity. Here, supraspinatus, infraspinatus, and teres minor attached. Here is subscapularis, lesser tuberosity. Then we have the shaft of the humerus. So, and this is your surgical neck. And here you have attachment anteriorly, that is pectoralis major. And here you have attachment that is your deltoid all the way from here. Deltoid attachment. And just to recall here, we have a nerve coming from brachial plexus to this, that is your axillary nerve. So these all things you need to remember when you are studying proximal humerus fracture. So if you see, we have 4 parts here. One part is head of the humerus. This is head of the humerus is 1, greater tuberosity is 2, lesser tuberosity is 3, and the shaft of the humerus is 4. So this is 4, depending on the fracture in between, either 1 and 2, 2 fracture, 1, 2, 3, 3 fracture, or 4 fracture. We classify by NIRS classification, 1 part, 2 part, 3 part, and 4 part classification. Okay, depending on the complexity or involvement of the fragment. So once the fracture is there, what is the direction of pull? As I told you before, the muscles attachment of the proximal humerus, this is your greater tuberosity. So we have subscapularis attached, so it will pull the fragment proximally. Whereas subscapularis attached to the lesser tuberosity, it pull the fragment in the form of internal rotation. It is superior. Then we have pectoralis major will pull the distal part of the fragment towards the medial side, towards the body. So this is direction of pull of the various muscles which attach to the proximal humerus after patient sustained injury or the fracture to the proximal humerus. So what is the presentation? We have the pain and swelling following the injury. So patient will have pain and swelling and decreased movement as a sign of the fracture. There is extensive ecchymosis because there is a lot of vascularity around the proximal humerus and there is a lot of loose tissue. So chest, arm, and forearm, there is bruises as we saw in the introductory case. Then we have involvement of the axillary nerve. So axillary nerve is so we have regimental batch sign positive. We have studied about regimental batch sign in the previous shoulder dislocation discussion. Then we may have patient may have arterial injury and there is concomitant chest wall injury in the form of wrist fracture or patient will have emphysema. So this is various presentation following the proximal humerus fracture. So this point is very important because it was twisted many times and asked in your exam also, which is the commonest nerve involved. Axillary nerve is the commonest involved. Second is suprascapular nerve is the second common. Suprascapular nerve enters from the brachial plexus and it goes into the suprascapular region. Then here behind the spinous process, it moves on to the spinous infraspinatus. So it supplies the supraspinatus muscle, it supplies the infraspinatus muscle. So most common nerve involved is axillary nerve. Axillary nerve present with the deltoid and pectoral teres minor supply, whereas suprascapular nerve supplies supraspinatus and infraspinatus. So if patient is having axillary nerve involvement, patient will have regimental batch sign positive. So this is regimental batch which is worn by army people. So over that area, there is hyperesthesia, lot of loss of sensation. This is the axillary nerve. It is very in close relation with the proximal humerus and mostly surgical neck of the humerus. So if patient has involvement of the proximal involvement of proximal humerus in the form of fracture, then they may develop involvement or nerve injury to the axillary nerve. So they have this area lack of sensitivity and involvement of the deltoid and teres minor muscle. So this is otherwise called as regimental batch sign. So here the point to remember is there are two nerves which are commonly involved. The most common is axillary nerve followed by suprascapular nerve when patient has fracture of proximal humerus. So once you have diagnosed it, you need to go for treatment. So here we'll just do a small exercise regarding the fractures. So if you see the patient is having only two parts fracture, this is one part, this is two parts. So first part is the greater tuberosity. So when there is a fracture, greater tuberosity is pulled by subscapularis and goes into proximal displacement. Here you see there is a surgical neck humerus fracture. So when there is surgical neck humerus fracture, here is the attachment of your pectoralis major muscle. It is pulling the distal fragment towards inside. Then if you see here, this is a this is again two parts, one part and two parts. This is three parts, almost four parts. So this is head of the humerus at the anatomical neck. So one part, greater tuberosity, two parts, and lesser tuberosity, three parts, and shaft of the humerus, four parts. So lesser tuberosity by the action of subscapularis, whereas greater tuberosity, supraspinatus. Then we have the pectoralis major pulling the shaft of the humerus toward this side. So this is how the four-part fracture can be seen on X-ray. So here are the various X-ray manifestation following the fracture. So one part, two parts, and four parts. Two parts, three and four parts fracture. Then what is the common association? Sometimes though this fracture has association with humerus dislocation, proximal humerus anterior or posterior dislocation. Here you can see on CT scan the head of the humerus is dislocated posteriorly. So there is a patient developing dislocation along with the fracture. So once you have diagnosed, how will you treat this fracture? So most of the time, no, in old osteoporotic patients, old and osteoporotic patient, they need just a sling. So we can either use sling or arm sling pouch to give rest and immobilization. So as we can accept the amount of malunion in this patient because they are very osteoporotic. Any maneuver to fix the fracture may result in failure. Or the other treatment modalities we can use it. We can either do closed or open reduction. We can fix it with K-wire using the K-wire here, or we can use the plate also. So closed reduction and K-wire fixation, open reduction and plate fixation. And if patient is having a fracture very comminuted with a lot of damage to the head of the humerus with the intra-articular extension and all, the only option left is you need to remove the damaged part of the proximal humerus and replace it with the artificial head. So it is called as shoulder joint replacement. So we can go for shoulder replacement in very communicated and badly fractured proximal humerus. So what are the complications of proximal fracture humerus? So nerve damage. Nerve damage. For what is a common nerve? As I told, axillary nerve. Axillary nerve, it supplies so infraspinatus. So it supplies deltoid and teres minor and the regimental batch area. This is why I am telling this again and again. You should not forget because it is very important part in your theory and practical examination. So and so supraspinatus muscle and infraspinatus muscle when suprascapular nerve is involved. So this is second most common. This is first most common nerve involved. So here we have regimental batch sign positive. Then comes your vascular injury. So if the patient has very bad injury, patient may have axillary artery or vein involvement. So arterial or venous involvement. And this fracture, no, they have very good vascularity. If you won't treat also, most of the time they will unite in malposition. So patient will have malunion. Non-union happens when there is a anatomical neck humerus fracture because vascular supply at the anatomical neck of the humerus is little bit compromised. Then if patient has malunion, intra-articular fragment, anything, patient may land up in shoulder joint arthritis. So these are the various common complications following the proximal humerus fracture. So that's all for the today's class. Please like, subscribe, and share my channel. And if you need any specific topic, just message me in the inbox, and please give feedback in